Thank you, Dr. Ghobrial, and thank you, Dr. Kumar, for those initial presentations. I think the work that you're doing is so important because what it leads to is an understanding of myeloma. So not just of these precursor conditions, but even myeloma. And sometimes patients can go kind of back into this. It's not really like considered MGUS, but an MGUS-like state where, and what you're learning is going to apply to those patients as well too. So I just appreciate you both so much. And I would like to invite you both to kind of go back and forth while we're doing these questions. I think the first question is a great one, and I'm going to go back and forth between the Q&A and some of the emailed questions. CJ was asking, how common is it to have clonal evolution in smoldering myeloma prior to treatment? And then what kind of implications does this have on the severity? And can someone with smoldering myeloma bank their stem cells for use if they become active? Like, is it better to do stem cell collection maybe? But that's an interesting question. Why don't we start with you, Dr. Ghobrial, and then Dr. Kumar, please jump in.
Sure. So that's a lot of questions in one. So clonal evolution means that the cancer cells are not all the same. There are different types of cancer cells within each patient, and we call those clones. And we know that clonal evolution does happen. And in fact, we have found that almost every single change that you think will happen in myeloma may already happen in smoldering myeloma, but they're small in size and they start competing with each other. And only when the bad clones are overtaking, which is basically Darwinian evolution, they're taking over the clone and they're getting bigger and bigger, they're the ones that lead to myeloma progression. So yes, clonal evolution happens way before you get active myeloma, and then it starts getting worse and worse later on. The second question was about stem cell collection. In many of the clinical trials we are doing right now, we do collect stem cells early when you're in a good remission, especially after we give you Revlimid, because we want to make sure that you do not have any problems later on. So we bank them, we store them, and then we leave them alone for later on.
And then Dr. Kumar, do you want to address clonal evolution at the MGUS phase as well? Because that's an interesting concept.
Certainly. I think, as Dr. Ghobrial just pointed out, there is the cell that is the plasma cell that's continuously changing over time. We know there are subtle changes. There are also some changes in the genetics of these, or the genetic makeup of these cells over the evolution from Mgus to smoldering to active myeloma. But alongside, I think equally important are changes that's happening around it. Dr. Ghobrial briefly mentioned about the immune system, and that is a major component of what changes along that spectrum, in addition to the tumor cell. But we also know there are changes that are happening in what we call the bone marrow microenvironment. There are the other types of cells that co-inhabit the bone marrow along with the plasma cells. And we believe all those different components change over time, and it's the cumulative effect of that that eventually allows the active myeloma to kind of break out, so to speak. And it's an interesting question with the stem cell collection, and we don't really know. I mean, the two problems with collecting stem cells in the smoldering phase. One is obviously we don't know if somebody will eventually need it or not. So, the discomfort and the cost of collecting and storing it for a long time obviously is one. The second is, we don't know if collecting after you get some treatment and the myeloma, especially the initial treatment of myeloma right now, is quite effective in getting the myeloma cells to really low levels. So is it better to collect the stem cells at that time versus collecting that when you are smoldering phase? We don't know the answer to that question either. So I don't think we would routinely recommend that somebody collect stem cells in the smoldering phase unless they are going to get treatment for the smoldering myeloma as part of clinical trial, or because they have high-risk smoldering. In that situation, I think it would be a prudent thing to do to collect and store some cells before we treat for a long period of time.
Mm-hmm. I have kind of an extension question of this. So I've heard some people starting to talk about collecting T cells, and storing T cells for future CAR T products or whatnot. So Dr. Ghobrial and Dr. Kumar, you both were talking about how the immune system isn't totally normal. There are, issues with it because you have these precursor conditions. So at what point does somebody do that or think about doing that?
Yeah, it's a wonderful question, and the question of immunotherapy early on. I mean, we know that Revlimid is in a way an immunotherapy, and we know that it worked in smoldering myeloma, even if patients did not have a deep remission, which tells you that the immune system, when it's activated, it can control the disease. So can we go back and re-control the disease, keep everyone in an Mgus-like stage by having the immune system on the check, on saying, okay, I'm going to control you? And we are working on developing actively cellular therapy trials in the smoldering area. I would say more in the high-risk smoldering myeloma because of the potential toxicity of all of those areas. So we are working on something called NK cells therapy, where we take your own NK cells and we can activate them and then give them back to you. The same idea of CAR T, you can take your own T cells and activate them. It still is early, it's still in the infancy because CAR T still has a lot of toxicity. But as we improve on this and as we develop bispecific antibodies and other ways to activate the immune system without causing toxicity so that we do not do any harm, then potentially that could be of benefit. Of course, think of vaccinations and so many other ways of enhancing the immune system and how we can harness all of that to prevent progression.
Dr. Kumar?
Yeah. I think it's important. It's going to be an important question for the future. What is the right time to collect those T cells for immunotherapy? We know those T cells, the immunotherapies are going to be here forever, I would think. The question is going to be at what point are we going to end up using those? So I think we still need to do more studies to understand what is the best time for the immune system, for the collecting the immune cells. Is it before we start treatment, or is the harm from the myeloma more, or is it the harm from the treatment more for the T cells? So I think until we have better information, I think what probably is going to happen is as we collect cells for the stem cell transplants, we're probably going to end up collecting maybe some T cells and keeping them in storage. And depending upon where the T cell therapies are going to be, we could be storing the stem cells for a future transplant or storing the T cells for a future immunotherapy.
Right. I've been fascinated by that question recently. So we have a question by Paul who said, in 2015, Dr. Ghobrial said we were treating patients too late. And since then, there have been many discoveries. So if you have high-risk smoldering myeloma, what is the criteria to determine when and if to start treatment? This is kind of in a broader context, in my opinion, because I've heard some of you as experts say, a lot of patients may be just misdiagnosed and may have active myeloma. So anyway, do you want to address that issue? High-risk smoldering, how should you be treated? And what if it's not actually high-risk smoldering?
Yeah, it's a wonderful question. And if you think about smoldering myeloma in general, it's a very heterogeneous population. There are people within smoldering myeloma, and you can look at what is considered smoldering myeloma. If you say just 10% plasma cells in the bone marrow and put everyone there, there are people who may never progress and they look more like an Mgus. You do not want to treat those patients. You want to leave them alone or potentially, think of prevention, but not treatment. And there are people who are marching towards myeloma, are almost myeloma. And these are the ones that we call right now high-risk smoldering. The problem, again, is we are not very good. We are not perfect in predicting when will that happen. And we are developing factors. So, for example, 2220 that Dr. Kumar said, 20% plasma cells, 20 light chain ratio, 2 gram M spike can give you some accuracy there. The problem is that if you have 50-50 chance, can I improve on that? And his own genetic data said that it can improve up to almost 70% chance. Now we're starting to get into, we are even more accurate. The data that we developed, as well as Mayo, says, okay, can we be more accurate with the genomic data? Now we are getting into this almost ultra high risk. There are people who have evolving M spike or evolving light chain, or the hemoglobin keeps decreasing. These patients likely also have an extremely high risk of developing myeloma very soon. And these are the patients that currently we want to do something to treat them on clinical trials to prevent progression. We do want to make a difference, and it's only by changing the standard of care can we make a difference. So that's why we would encourage everyone to consider clinical trials, to enroll on them, because then we can show a huge difference of what is the survival benefit from early treatment. There is already lenalidomide and dexamethasone, which we've talked about. as long as we're sure that we are treating the right population of patients who truly have this smoldering myeloma, who will benefit from Revlimid and dexamethasone. So be careful, talk to your experts, talk to your doctors before you treat or you do not treat, because this is a big area of work that we're all working on. And Dr. Kumar and I have been really in big discussions with many experts on how can we define this better and how can we develop the better or the best therapy for our patients, because it's not one size fits all. We don't think that Revlimid and Dex is the right choice for everyone, but it may be the perfect choice for some people, and then someone else may need 3-4 drugs. He has a trial of carfilzomib, lenalidomide, and dexamethasone. That would be for higher risk patients. We have multiple trials for the very high risk. So again, not everything is the same, and that's why we work in this, and we have tailoring therapy, precision medicine for every patient, so that we can have different trials for different patients.
Yeah, I think it's, again, 3 important questions, right? The first one is, do you have active myeloma that needs therapy today? And I think that's where the new criteria that was developed a few years ago is become critically important. And I think the most important aspect of that is, you have to have more sensitive imaging studies like the PET-CT or an MRI scan done, in addition to the traditional blood and urine tests that we have done for decades. So once we are 100% sure that this is not active myeloma, then the next question is it high-risk smoldering myeloma where we need to do something? And then the question for that particular group of people, however they identify them to be high risk, is do we treat them, just as Dr. Ghobrial said, with lenalidomide or lenalidomide dexamethasone based on the clinical trials that's out there? Or do we consider, trying to go to a clinical trial to answer the questions that are unanswered? And one of the major questions being, with this high-risk smoldering, should we be treating them like myeloma, or should we be treating them with lesser therapies or less intense therapies like what has already been studied? And then finally, I think one of the most important thing is, who are those people who are less likely to get to myeloma? I think that's equally important, because we can reassure them so that they don't have to constantly worry about it.
And a follow-up question on that is, I've heard other experts say, if you are treating smoldering myeloma, is it better to treat as if you were treating myeloma, or you're going to develop resistance if you just give a single drug or a doublet or something like that? Do you both want to address that? And Dr. Kumar, maybe you want to start.
Yeah, definitely. I think that has been the top question, I think, in all our minds as we set out on doing these clinical trials. So I'll ask and answer the first question first, or the second question first, which is, are we actually harming people, right? Are we making people's myeloma more resistant? And the short answer to that, based on what we know, is no. Because when the Spanish group did the clinical trial looking at lenalidomide dexamethasone for the high-risk smoldering myeloma, they looked at people, how did they do after they got myeloma? And the ones who are on lenalidomide dexamethasone or the ones who did not get any treatment, both of them did equally well with the subsequent treatment they got for myeloma. So it's unlikely that we are changing the myeloma so dramatically that subsequent treatments are not going to work. And it's going to become less and less of a question, because we have so many choices that are coming up in terms of new therapies. So we can always use something that is different. And the second question, I think, what is more important for all these trials is, it's not just, is the myeloma going to come anyway, but it's just going to come a year or two later. I think that is less of a value compared to, can you make people live 2 or 3 or 4 or 5 years longer, or maybe the myeloma will never come back. And those are the questions, I think, especially from the Spanish trial, we know that the overall survival is better, but there is obviously criticism because that trial did not look at very sensitive scans to make sure we are not treating just myeloma and smoldering myeloma only. But there are trials that are ongoing trying to answer that question. And once we are convinced that the overall survival is also improved by that early measure, then I think we will routinely start treating patients with high-risk smoldering.
Mm-hmm. And Dr. Ghobrial, maybe I can ask you a different question, because it's a really good question and we have a ton of questions. So I'm going to get through as many as we can. Leanne had a question. She said, I have biclonal smoldering myeloma, and I have a friend who has biclonal smoldering myeloma as well. How does it differ from monoclonal? And then she's been told it ends up better in the long run. Is that true? Is it treated differently? So interesting.
No, very interesting question. So by clonal gammopathy, and I would say Shaji Kumar would probably answer this better than me, is you have two different types of clones that are being secreted, or two different types of antibodies, or maybe one light chain and one has the heavy chain and light chain. So your cells are sort of deciding, I'm going to only secrete an IgG kappa, and then another cell, also a different clone within the myeloma, may secrete only the kappa light chains. And that may happen in many patients. And sometimes one of them will respond and the other one will only be the one that's going on. So it doesn't mean that it's different. It just means that you have multiple clones and some of them are secreting different antibodies. That's the short answer for that. And I don't know if Shaji wants to add to it.
Yeah, no, I think the two clones, as Dr. Ghobrial already mentioned, it's not very common. It's about 5% of the monoclonal gammopathies that we see who have two clones. Typically, one is large and one is small. Mm-hmm. And if that patient eventually gets to myeloma, it's usually the bigger clone that usually takes off and the smaller one just disappears over time, almost consumed by the bigger clone of cells. In the setting of smoldering, it's very, very uncommon to have two clones because one of them, whatever was there, that one has kind of dominated over time. I don't think we have any data to say that people with two clones are going to do better or worse compared to the ones with just one clone in terms of the risk of progression. But the bottom line is, if that does develop into myeloma, it's going to be the bigger one that's going to take over.
Yeah, and I'd like to maybe go back to the same question that you asked Shaji before, is what is the benefit from Revlimid and Dex? And we all agree on that. I think there is so much to be answered, so many questions to be answered on who should be treated, for how long should we treat you, and what will happen after you stop the therapy. And that's why we would highly encourage you to consider clinical trials, because we will never answer those questions unless we systematically do it and look at all the data. And then we can give you back that answer. We can tell you, this is the best choice for you. We think that multiple myeloma is not one disease, and we do not want to do the same thing that we did 15 years ago for myeloma, treat you with one or two drugs. We want to truly benefit from all of the therapies we have right now and make some distinction between an 11-14 smoldering, a 4-14 smoldering, a hyperdeployed smoldering. You may not all be the same, and we should not be treating you the same way or for the same types of therapies for you.
Mm-hmm. Yeah, I totally agree with that. And we are highly supportive of participation in clinical trials. I think sometimes patients think, oh, that's my last option, or I should never consider it, especially at these early stages. This is the best time for you to consider it, because you're working with like the two of you who are just leading edge in what's happening in the field. And you're right, we won't come to those conclusions. So if patients want more information and a lot of these questions answered, it's by joining clinical trials. So please do that. And I always stress too, because it's so clear that this is so nuanced, that it's so important to see a myeloma specialist like you two with these precursor conditions. So get a telemedicine visit, or, it's the perfect time to do that, right? You don't have to travel. But even if you had to travel once a year or something like that to either of these specialists, go do it. So it's really important. If you are working with a general oncologist and you don't necessarily, because saw some questions about, I don't necessarily trust my general oncologist, you need to get a second opinion. It's not a problem. It's easy. Just have somebody like these two do that. And I'm sure that they have, telemedicine in place. So okay, I have a couple questions, and these are kind of related with different diseases. We have somebody asking a question about the relationship between Gaucher's disease, and somebody else says, is there a link to autoimmune disorders in the Mgus stage? So could you both address autoimmune disorders and links? We asked this question actually in HealthTree. Do you have a pre-existing autoimmune disorder? And the greatest one was at 6% of patients who had psoriasis. So it wasn't like a broad spectrum that we saw with the patients who participated in HealthTree, but can you share what you know?
Sure, maybe I can jump in. So two things. One is the autoimmune disorder. So when Dr. Kyle did his Olmsted County study, we did, he had gone out and screened everybody to see who has a monoclonal protein. So it was in a community study, identified people with Mgus. And when you look at associations with other diseases that goes with Mgus, there was a slightly higher prevalence of autoimmune disorders amongst those people who had monoclonal gammopathy of undetermined significance. It's not a huge association. It's, those patients had, for certain autoimmune disorders like rheumatoid arthritis, there was about a twofold higher risk. And again, it's low but in absolute terms. So the second thing is, we think that there might be a component of inflammation that eventually leads to the development of monoclonal gammopathy in folks. So I think that is an active area of investigation. In terms of Gauchers, I mean, there was an interesting paper that was published by Dr. Drobker, where he showed that a lot of that monoclonal protein that is being made is directed towards what happens in Gauchers, the protein or the phospholipid that accumulates in Gaucher's disease, and the monoclonal antibody seems to be, or the monoclonal protein seems to be directed against that. Now, how does it matter for the routine patient with monoclonal gammopathy? We don't know if that is the trigger in everyone, or is it just those the small proportion of patients described in that study.
Mm-hmm. Yeah, and I would say, if you think about it, what made the plasma cell decide to become a cancer cell or a precancer cell? For all of us, every day, all our cells are dividing, and all of them are prone to an error, a mutation, a change. And all of those cells usually get cleared by the immune system. And it's only when your immune system is in this array, it's a little bit messed up and it didn't recognize that cancer cell, or the cancer cell that survived was smart enough to change the immune system not to recognize it, that it stays and it becomes Mgus. So there is a very strong connection between cancer cells and the immune system. And if your immune system is upset, whether it's by autoimmune diseases, whether by inflammation, whether by stem cell mutations, what we call CHIP mutations, or by anything else, that balance between cancer cells, especially that, remember, plasma cells are part of the immune system, they're already part of that system, tells you that this will happen and this will lead to progression, and whether it goes on to myeloma or not. So the balance between the immune system and plasma cells and which one started the whole process is very hard to know, and we're still just starting to dissect this apart to say, was it the immune system that was bad and that's what led to Mgus? Is it people who have autoimmune diseases, certain autoimmune diseases, not all of them? Maybe some of them are actually activating the immune system so much that you may not get a Mgus with it. So we really need to dissect this much, much more, and hopefully we understand this better.
Okay, there was another question too. I think a lot of people want to know, like, what are early, relationships and things like that, kind of like we're talking about with inflammation or inflammatory disorders or whatever. But another Jenny was asking, does high blood ferritin, which is iron level, right, have a correlation to progression from Mgus to myeloma?
It's a good question. I don't know if anyone has really looked at the ferritin levels. I mean, typically, if you have very high ferritin levels, you really want to find out why that is high, because there are usually some disorders that can be associated with it, especially some hereditary conditions. And if someone has a high ferritin, definitely get that checked out.
Mm-hmm.
Yeah, and I would say again, some relation with inflammation may be part of that. So looking at the whole picture.
Mm-hmm. Okay, let's see. Joanne was kind of asking in general, you talked about different approaches to the clinical trials. I think, could you go over them a little bit in more detail? Because I think you mentioned the ASCENT trial, Dr. Kumar. It's the ASCENT trial, right? Which is the quad. Is that the name of the trial, or I have that wrong? For the Kyprolis and the quad for smoldering myeloma patients. Can you just kind of outline in general, what are the different clinical trial approaches? So we have Lendex, we have the quad therapy. What else is available that patients could consider?
Right. So I think we have to kind of take a step back and say, what are we trying to achieve, right, with the high-risk smoldering myeloma? So one approach is, can we just prevent it from becoming myeloma? So can we use something, so maybe delay the myeloma from coming. The second is to prevent it from ever happening. And the third is, can you cure that completely, that the malignant or the clonal plasma cells are not there at all? So the first is kind of the trials that have been done already, like using just lenalidomide alone, like the ECOG trial that showed that there's delay in a transition from smoldering to active myeloma. But the question that always comes up is, can we just delay it, or can we just, can we do something more than that? Should we be treating them like myeloma? That's the second question that comes up. So there are trials ongoing looking at, for example, daratumumab in combination with lenalidomide and dexamethasone versus lenalidomide and dexamethasone. So that's asked the question, should we be a little bit more aggressive than just trying to give one drug? Because in newly diagnosed myeloma, we know 3 drugs are better than 2 drugs. And then the third, kind of the other extreme is, if, as Dr. Ghobrial pointed out, the question of DCIS, is it something very early on, more amenable to getting eradicated? Should we be trying to use all the effective tools that we have, but in a very time-limited fashion? And that's the ASCENT trial, for example, where we are using the combination of carfilzomib, lenalidomide, dexamethasone, and daratumumab. So all 3 very effective classes of drugs. We give it for 2 years, relatively intense therapy, and then we stop. And the question there is, have we managed to get rid of all those bad cells, or at least most of it? And whatever is left behind, maybe the body can take care of it. And maybe the question of myeloma coming up, maybe it will never come up again.
Yeah, I mean, I absolutely agree. I think we're all looking at smoldering myeloma as a spectrum, and certain patients, again, other than looking at the type of myeloma, 1114, 414, but certain patients who are almost into the active myeloma, we want to think of a treatment that is used for myeloma and we're just bringing it early. So this is where the KRD, DARA KRD, we're opening a DARA RVD, basically active myeloma therapy, bringing it early. So all of those options that we use for myeloma, let's try to see will they work much, much better and give you deep remission at the smoldering setting. So that's one approach. Then the other ones is using 3 drugs. So we know that Revlimid and Dex works. Let's think of adding an antibody to improve on that, but we're not going all the way to active myeloma treatment. So these are the DARA RevDex trials that are ongoing right now in ECOG. There will be a phase 3 trial going on and opening soon, isatuximab, Lendex also, that will be available. And we had done ixazimib Lendex, so taking the oral Velcade-like, but bringing it early, and we had really good responses. The study is completed and closed, but we're still enrolling, or we're still looking at many patients on follow-up. So that was 3 drugs. We've done ELO Lendex. So the 3 drug combinations have been done, and many of those are ongoing right now. And then there will be different approaches, hopefully in the future, of if you're an 1114, you should get a venetoclax option. If you are a very high risk P53-17P, you should get something completely different. This will be the next generation of options that we should hopefully develop for you as immunotherapy, as precision medicine in the coming years. And it's nice to have all of those options, but talk to your doctor, talk to many experts, because one option may be the best one for you versus another option. And because you do have options, which is great, you have to think of what is the good, what's the risk and benefit for you.
Yeah, I agree. But consider a trial. I guess that's the big message is look into these. Ask your doctor. If your doctor doesn't have any trials open, particularly at their facility, there are other facilities that have them open. So you might have to travel to go participate in one, but you might be able to get some of the care at home too. It's not like you have to just go live, near one of your facilities to even participate. So I want to make sure patients know that. Okay, I have an important question. Bonnie is asking, why do doctors say there are no symptoms with Mgus? Most of us know that there are symptoms. How often should we be tested? How often bone marrow biopsies? She has bone lesions, so does that automatically move her to myeloma? And she has stage 3 kidney disease. So to me, that sounds maybe like active myeloma, not Mgus, but how do you address that?
Good.
Dr. Kumar, do you want to start?
Yeah, absolutely. So I think the key thing is, if there are bone lesions that are what we call the lytic lesions, or the punched out hole-like lesions in the skeleton, that would be myeloma and would need treatment. One thing we had to be careful is the old ways of looking at the bone lesions, like the traditional X-rays, that are not very sensitive. Almost a quarter of those people where they are negative, they could be positive on a CT scan or a PET CT, whole body low-dose CT scan. Sometimes there can be conditions in the bone called fibrous dysplasia, which can look like small areas of lytic lesion, and that in that situation, the PET CT can help you distinguish between the two. Now, while kidney disease is it can be seen in about a third of the patients with myeloma. Myeloma is not the commonest reason why someone would get kidney disease. So we want to make sure that if someone has kidney disease and a monoclonal protein, they are not automatically means myeloma. So getting the help and making sure that the kidney disease is related to the monoclonal protein is important for the diagnosis.
Interesting.
Yeah, I would agree. I say Mgus is such a fascinating disease, and when people say it is asymptomatic and it's easy, it's not. There are so many things that happen with Mgus. There are kidney damages, just like we said, and it could be MGRS, monoclonal gammopathy of renal significance, and we need to understand why and what's going on. It's still not myeloma, but it has its own changes. There are people who have neuropathy, but they also have Mgus, and we need to know why. There are already changes in the bone marrow and in the bones themselves. Actually, Mayo Clinic has shown that many people have something called osteopenia or osteoporosis with Mgus. So although you don't have lesions, your bones are already changing. And we know that the immune system changes. So people who start saying, I have a lot of infections, that can happen also with Mgus. So there are lots of things that happen with Mgus. And that's why it's important for us to really look at it carefully, to listen at you, and to also do more studies to understand what's causing it.
So one of Evelyn's questions was like, how often do you do those biopsies? And then how often do you do the MRIs and the more sensitive imaging?
Yeah, typically, for patients with smoldering myeloma, from the first diagnosis, we would repeat everything in 3 months to get a sense of the tempo. And if somebody is, low risk of progression, then maybe we would see them every 6 months. If they're at higher risk of progression, maybe definitely every 3 months. And that 3-month evaluation would involve primarily looking at what the M spike is doing, what the blood counts are doing, making sure there's no increased calcium or increased creatinine. In terms of the imaging studies, we generally tend to do that once a year with a whole body low-dose CT scan. And that would give us a tell us early on if something's happening with the bone in terms of change.
Okay, great.
Yeah, and I would add, I would say that the hope in the future is that we do something called liquid biopsies, because bone marrow biopsies are not fun, if I can say that lightly. Well, I've heard a few people who volunteer for it, but usually it's the wife or the wife is saying, well, why don't you get a bone marrow biopsy, honey? So with my patients, but it's really not the easiest thing, even when we make it a easy procedure. And the hope in the future is that liquid biopsies, which is basically your blood sample telling us what's happening in your bone marrow, will help us with that. So your cancer cells shed their own DNA, they shed basically their information in the blood. And the hope is that we get all of that information from your blood sample. And we are getting almost there. There are lots of studies. MMRF just launched their Cure Cloud, which is basically a DNA-based approach that we are going to have for smoldering myeloma. And we're hoping to develop an even more sensitive test so that people can get liquid biopsies.
Mm-hmm. Yeah, that'd be great. Yeah, everybody would love that. Okay, we have 2 questions about eye issues. So can corneal deposits, this is from Robert and Gary and Joy. Can corneal deposits be seen with smoldering myeloma? Are they related to disease activity? Will they respond to treatment? And then would eye edema move a patient from smoldering to high-risk smoldering? Does that have anything, did eye toxicity or eye issues, symptoms have anything to do with both Mgus, smoldering myeloma, or progression?
Yeah, so there is a condition where the immunoglobulins can get deposited in the corneal, what we call the corneal basement membrane, and that can sometimes be symptomatic. Obviously, as with anything with monoclonal gammopathy, that causes symptoms, right? So the myeloma is the biggest chunk of that whole thing. And Dr. Ghobrial just mentioned about monoclonal gammopathy of renal significance. So the fundamental thing, I guess, to think about is if you have a monoclonal protein, and if you have some problem that's related to that, which doesn't even fit into the diagnosis of myeloma, we would want to treat that. So it could be, again, something happening in the kidney because of the monoclonal protein, whether it's eye. There are some skin conditions associated with it, like scleromyxedema. There are clearly, obviously, amyloidosis is something that is a much bigger group of patients where the monoclonal protein is doing something bad. But the bottom line is you can have pretty much any organ it's affected by somehow, sometimes by that monoclonal protein. And if you can prove that is the case, then the only way to get rid of the monoclonal protein often is the type of treatments we use for treating myeloma.
Mm-hmm. Okay. I feel like I can't keep up with the questions. So Jerry is asking, is ITP related to Mgus? And I don't know what ITP is. So I'll let the two of you answer that.
Yeah, the ITP is immune thrombocytopenic purpura. It's basically an autoimmune condition that can cause your platelet counts to really drop. Can it be associated with Mgus? We do see them both together. It's often difficult to prove that they are related because both are not uncommon conditions. So they can definitely happen together. And I think that's the biggest challenge with monoclonal gammopathy of undetermined significance, right? One thing is the worry that will myeloma happen someday? And the second thing is when anything happens, you worry, is it somehow the Mgus doing this? And that can sometimes be a challenging thing for physicians to figure out and also for patients to kind of come to terms with.
Mm-hmm. Yeah, and it's yet another example of an immune cell problem that causes both of them.
Mm-hmm. Okay, we have another anonymous question who says, you mentioned higher propensity for African Americans. Does this include people that are biracial? That's a good question. And can people who are biracial join the PROMISE study?
Yes, absolutely. So the PROMISE study is open for anyone who self-identify as having this high risk. So whether you self-identify as African, African-American, Black American, Black, we'll welcome anyone. We will never say that that's an issue at all. And again, inheritance is inheritance. You inherit 50% of your genes from the father or the mother. So you do have that potential risk if we can understand better what really leads to that increased risk of multiple myeloma. So we would welcome anyone. That should not be an issue at all.
And then I saw some questions also about returning the results from the PROMISE studies and the PCROUD studies. Can you address that, how you're planning on doing that?
Absolutely. So the PROMISE study, when we get the results back from Mayo Clinic, we look at them, and the people who are positive, we call them. I usually call many of you, or you've had many calls from members from physicians or nurse practitioners from our group, and we make sure that you are part of our team. We call that the next stage of the positive cohort people. We call this the myeloma care group, and we make sure that we refer you back to a doctor who knows very well Mgus and smoldering myeloma. We follow you for long term, so every 3 months or 6 months or once a year, we check on you. We get the blood samples again for follow-up, and you are invited to be part of this community of, if there are trials available, if there are other options available like Impact, then we will let you know by email. And we hope that indeed, just like Jenny is doing, we have webinars, educations, other things available for everyone. So that's the PROMISE study. When we give you back the information, you become part of that community of, just like PCROUD, we give back the information in aggregates, not in person, because we cannot give you back your own data unless it's clinically approved, something called CLIA approved. But what we're hoping to do soon, because we've heard that comment from many people, is can you release that information more often? And we are actually working on having every 3 months release of aggregate information to everyone. We're also working on bringing CLIA-approved tests so that you can get your own information back to you specifically. The first example of that is the MMRF Cure Cloud. We're hoping to bring in more and more so that when you give us your blood sample, we know that that's very precious, and we're hoping to give you back that information. But already you've changed. PCROUD has resulted in many studies that will help us change the practice for everyone else with smoldering myeloma, and hopefully with Mgus also.
Mm-hmm. And Dr. Kumar, are there any other studies outside of some of these observational studies? There are no treatment studies really for Mgus, right?
So there have been some studies looking at things like green tea, for example. We want to do those trials with, something that doesn't have significant toxicity, because again, the risk of progression is so low in these folks. We don't really want to be harming them in any way. But things like green tea and a variety of other supplements, those are being looked at in clinical trials. The problem is you really need a lot of patients for this, right? So sorry, Erin.
No, absolutely. I was going to say metformin is another option. We will be opening soon with one of our colleagues from the population science group a metformin study to see if it does indeed make a difference in preventing progression. Again, for Mgus and low-risk smoldering, there has been retrospective studies that were done. Now we're hoping to see if that will work. But just like Dr. Kumar said, these need a long follow-up. We need a lot of patients to see are those changes in metabolic pathways will they make an impact or not in our patients?
Yeah, and Justin had a question, and I saw a lot of questions about this. Like, what can I do? What can I personally do outside of therapy, any type of therapy, to slow progression, eliminate progression? When your patients say this to you, what do you both say to that?
That's always that I can bet, that's a question that always comes up, right? I think the issue is there's nothing that's proven right outside of what we have seen from the clinical trials. But my usual reply is that you want to maintain a healthy lifestyle. You want to eat a balanced diet. You want to exercise. You want to keep yourselves as fit as you can. Outside of that, and making sure you monitor, you make your appointments and make sure your physicians monitor what's going on with the M spike. I wouldn't do anything outside of those.
Mm-hmm. Yeah, I totally agree. Sign up for some of those observational studies. They do make a difference because that's how we can understand how to treat better. If you have one of those other trials of green tea, metformin, exercise, there are lots of those studies that we're opening everywhere. It's good to join one of those, even if it's meditation. These are all very good to help. And then just like Dr. Kumar said, the most active thing you're doing right now is you are continuing to see your doctor, because when we monitor you, we can tell if you are going to progress, and that's very important for you to prevent it and to treat it early. The people who say, well, I've had it for the last 15 years, I'm not going to go see the doctor anymore, it's not a problem anymore, I would say be careful. We want to see you for a lifetime, even if we see each other to talk about kids and grandkids, but we want to see your numbers, and you are doing something by going to see us every year.
Yeah, it's really important. Okay, Stephen has a good question. So is Mgus just cancer held in check, or slow growing, or just precancerous? And if it's precancerous, like what's the difference at the cell level? Is it just early myeloma with no CRAB criteria or something like that,
And I think what we both were talking about in terms of it being a spectrum, right? I know everybody has Mgus before they get myeloma. We think the Mgus starts pretty early on, maybe in the early 30s, or maybe even just earlier than that if you had sensitive ways to look for those. And it's very slow, and not only a fraction actually gets to be myeloma. So I think it's what changes over time is something that we are trying to understand. So I think the best way to say it is precancerous, so precursor to myeloma. What changes? I think it's a sum total of multiple things in the plasma cells, outside the plasma cells, which all contribute to this multiple small changes that happens, and they cumulatively they get to a point where they just cannot push back, or the body just cannot hold it back anymore in check.
Mm-hmm. Yeah, absolutely. I mean, almost all other cancers have something similar. So something called dysplasia or carcinoma in situ, they're all stages where you get that first change. The cells or the DNA is unhappy. It's acquiring some changes that are almost like the myeloma, but they're not there yet. They're not able to grow and proliferate and get to the next level. And it only takes time, either from something outside, like Dr. Kumar said, the immune system, or a new change, a new mutation, a new hit happens in those cells that allows them now to keep growing. And for us to truly define at the molecular level which one is truly precancer, which one is truly myeloma going into myeloma is hard. Our definitions of Mgus and smoldering are still clinical definitions, 10% plasma cells, 3 grams protein. For us to get to the next level of saying this Mgus is predetermined to go to myeloma and this Mgus doesn't go to myeloma is important, and we would love to get to that level in the future.
Okay, great answers. A question about bone pain. And this could apply to Mgus or smoldering myeloma. So what causes bone pain in these early conditions, even though there might not be bone lesions showing? And then what do you do about it?
Well, typically they shouldn't have bone pains in the setting of Mgus or smoldering myeloma. There wouldn't be any bone lesion per se. But we know that bones do get weaker. And Dr. Ghobrial mentioned osteopenia before. So we know that patients with Mgus are at a higher risk of getting fractures. So definitely the bones get weaker. And we believe it's the chemicals that these plasma cells, even if they're not myeloma, they are secreting some of the same chemicals, what happens in myeloma as well. And that has a chronic effect on the bones, making it weaker. But that should not cause bone pains without the lytic lesions.
Mm-hmm.
Yeah, absolutely.
Okay. And Lynette is asking a good question as well. So when you think about, I know smoldering myeloma and considering someone high risk smoldering myeloma is not necessarily the genetic features, but maybe the progression or the level of disease or whatnot. But when you think about smoldering myeloma and you're working with like a 1Q gain or those types of things, no crab criteria, but you're looking at like 10 to 20% of plasma cells in the biopsy and on a 1Q gain. Are you looking at, treating, or how do you handle patients like that?
Do you want to go ahead and take it?
Sure. Yeah. No, absolutely. We put all the factors together. So
yeah.
We put the clinical factors. The 2220 is important because that's immediately there. But genetic data, genomic data is important. 1Q amplification is one of those that increases the number of cells. It allows proliferation. That's an important factor that tells us likely those cells are not going to be easygoing and they would progress. We put also what happened for you in the last year. Have you been progressing? Are you stable? We put all of that together. And again, I wish I can say we have the magic formula to say with 100% accuracy where we are. We're at the 50 to 70% accuracy right now when we put all of these together. And the hope is that we can get better. So yes, 1Q is important and it gets part of the clinical discussion that we have.
Okay, here's an interesting question. Someone was diagnosed with Mgus and smoldering myeloma a year later, not eligible for clinical trials. So how do you deal with the mental challenges of the diagnosis? What do you recommend for your patients?
Yeah, that's, it's always challenging, especially when you have a smoldering myeloma and you've been told that this is the risk of it getting to myeloma. You're always worried any small thing that you feel different is just a harbinger or just the first sign of myeloma. I think the key thing is to reassure the people, there are a lot of treatments for myeloma, right? So the first thing is take the worst case scenario that myeloma actually does develop. There are a lot of treatments that are available and patients with myeloma are living longer and longer. And with the current immunotherapies, we are going to continue to see that only improve. But again, the important to remember that, again, the majority of the patients may not actually progress from Mgus, and almost a third of the patients with smoldering will never get myeloma. So the key thing is to watch very closely. So, plan for the worst, but hope for the best. And I think just make sure that this is monitored very carefully.
Mm-hmm.
Yeah, I totally agree. I think it's important to be actively. So even though you're watching and waiting, you are checking on it regularly. And sometimes we go from the every 3 months to almost every month to see, are you at the point of you're going to need treatment or not? And the trigger of treat or no treat is really a decision that you have with your doctor, with you. And you decide, is this the right time for me to start the active myeloma treatment and think that that will prevent progression or not?
Now, Maureen had a question. She says, do these trials apply to myeloma patients who have had a transplant? And she says, Mgus is reappearing, but if you've had treatment already for myeloma, it's not really considered Mgus anymore, right? Do you want to clarify that?
That's true. That is not Mgus at that point. It's just myeloma that's kind of starting to come back. But as Jenny, you mentioned in the beginning of this talk, what we learned from Mgus could potentially have applications even at that point. If we can figure out why does Mgus go to myeloma, it's essentially potentially the same evolution happening, but in a much more compressed fashion, in a much more fast forward. And especially some of the changes that's happening around the tumor cells could be similar and could be utilized to try and control that cell from growing any faster than what it's doing.
Yeah, and I've seen fascinating patients who I transplanted 15 years ago, and I thought they were in amazing remission. They were cured almost, right? 15 years without any evidence of disease. And then slowly an Mgus-like disease starts to show up, and then they progress. So it's hard to know whether, is it now a new Mgus clone completely different than the prior one? Did they have all of this time a cell that just sat there waiting and waiting until it started to progress? All of this, to understand it better, is truly to go deeper. And what we learn in Mgus can be applied post-transplant in this MRD negative and then MRD positive disease in a very different way.
So do you treat patients like that who've had that really long extended time period as a newly diagnosed patient, like as if they were newly diagnosed, or how do you treat them?
Yeah, it's very hard to know. And again, I'm sure all of us have 2 or 3 patients here and there to truly understand what to do and to try and understand whether the new cancer is related or not related to the old one.
Yeah, it's, the amount that myeloma treatment has changed over the past 15 years. If someone hasn't been treated for 15 years, you're going to be treating them very differently, and just like what we would do for a newly diagnosed myeloma today.
Mm-hmm. Yeah, it's interesting. You've got so many more tools in the toolbox now, so it's that part is pretty exciting. Okay, Susan is asking a question about what is known about Mgus and peripheral neuropathy. Why does it co-occur with Mgus and myeloma?
Right. So peripheral neuropathy is one of the more common conditions that we find associated with Mgus. Again, in the same caveat, right? I think they are not uncommon conditions and can frequently coexist. There are some places where we can be absolutely sure that they're related. For example, some of the IgM Mgus, where we can detect a particular type of antibody called MAG antibody, which is directed against the lining of the nerves. Those ones we can be very sure that these are related. The other ones we are often, we are not sure. And in those situations, sometimes we just sit and watch and see what the tempo looks like. But if the neuropathy is getting worse rapidly, then we often try to treat with the least toxic treatment we can think of, trying to see if that would make a difference. And the biggest challenge is, let's say somebody has 2 grams of M spike and a neuropathy, and we treat them like myeloma and get their M spike down to 0.2, and the neuropathy doesn't improve. We still don't know the answer whether they are related or not. Is 0.2 sufficiently low enough, or do we need to get it even lower?
Mm-hmm. Yeah, I totally agree. It's the most frustrating thing for us to try and understand, are they related and what to do with it. We always think of amyloidosis, as we said, POEMS, which is a rare disease, but Mayo Clinic is probably the best place to talk about POEMS, cryoglobulins, anti-MAG antibodies. If it's an IgM, something like Waldenstrom. So all of those things come out as we start thinking of what to do with the monoclonal protein plus a neuropathy. And sometimes we never find the real reason, and we start thinking of how to consider therapy. There's definitely more work to be done there. We had a clinical trial of daratumumab because it's a simple, easy antibody to give, less toxicity for low-risk smoldering and high-risk Mgus, specifically for people who have neuropathy. For that idea in mind is, we know you don't have a lot of disease, but you have something that's causing a problem. Yeah. We just didn't have enough people coming on that trial, so it would be wonderful to think about another potential area to open that more for our patients.
Mm-hmm. And there were a lot of questions about the clinical trials, and Jennifer's asking, she's 84 and she has smoldering myeloma. Like, is there a difference in the type of trial that you might select or treatment you might get based on your age? And I saw another question from somebody who was really young who asked the same kind of question. Dr. Kumar, do you want to give that a go?
Yeah, so I think the clinical trials, I think there is no distinction purely based on age. It's all dependent on what can be tolerated without, I mean, in any cancer, we want to make sure the treatments don't cause too much toxicity. But in smoldering, it's even more important that the chance of toxicity is minimized, because we are having somebody who is otherwise asymptomatic, trying to prevent something that's symptomatic. But if in the whole course we give them symptoms that's worse than the disease, that doesn't serve any purpose. So I think it's 84 in excellent shape. Maybe we're open to doing something that's more aggressive. Maybe somebody who's younger, let's say 65, but he has a lot of other medical problems, maybe we may not consider a trial which is 3 and 4 drug combinations. Maybe we will try a more gentle approach.
Yeah, absolutely. As I get older and older, I think age is just a number. So I hope that that's true for everyone. But I would say that if you're in your 20s and your 30s and you have smoldering myeloma, we have to think, what's the long-term approach here? Is truly just the treatment that we have right now for myeloma may not be enough. And now we start thinking of immunotherapy, of other approaches that can give us that longer. We want you to go to age 100 if we can. So we start thinking, what else can we do to truly help you with that long-term? And we do have patients who are in their 20s and 30s with smoldering myeloma.
Yeah. A good question for Michelle is, should a smoldering myeloma patient, or maybe even an Mgus patient, Dr. Kumar, I'm kind of curious about that, do genetic or DNA testing? That's interesting, right? If you can already have mutations at the smoldering phase, what about if you go earlier? And then what test do you recommend, and how do you practically ask your doctor to do that test?
Right. So I think right now there are, Dr. Ghobrial's studies have shown that you can find these genetic abnormalities pretty much right from the beginning. But obviously over time, you accumulate more and more of those and get to a point where it transitions to active myeloma. So the testing, we don't have anything that is routinely used in the clinic outside of, individual hospitals have mutation panels. There are also some commercially available ones like the Foundation Medicine and others that are out there that can look for the commonly found mutations. And we know that in myeloma, at least in the relapsed myeloma, there's a few mutations that are commonly seen, so we can screen for them. So the same test can potentially be used even in smoldering or even in Mgus. Mm-hmm. But as Dr. Ghobrial said, we still are learning what to do with that information. So we don't want to necessarily find something abnormal and worry about it if that's not going to mean anything in the long run.
Do you think the test, like the NGS testing, is a better approach? Like, I don't know, if I were diagnosed with Mgus at the beginning, I'd kind of want to know what I was working with and then how it changed over time, because that might tell you something as a myeloma specialist that might be really important later.
Yeah, I think it's important to do this on the part of a clinical study, like the observational studies we are doing, so that we have a better sense of what does it mean. I don't think we fully understand what to do with those changes.
Yeah, absolutely. And again, many of the next generation studies that we have right now are not sensitive enough in the Mgus. Remember, Mgus is a very small number of cells, and some of them are normal, some of them are not truly malignant. So sometimes when people say, well, there weren't any abnormalities, or I had no FISH and cytogenetic changes, or I did a next generation panel, but it didn't detect anything, it's likely because the technology that we used was not sensitive enough to get to the single cell level. And this is what we are doing right now in the research level to get to that single cell level. And then hopefully we bring it to the clinic. So I would say be part of some of our studies, even if we immediately, that's what we're hoping to.
Okay, and we have so many unanswered questions, and I'm so sorry we can't get to everybody's questions. But I think we're going to end with one more question by Joanne. And this is kind of a relevant question in this time frame. She's just asking, it's hard to sit in quarantine and wait for a vaccine that may or may not work, with the added stress of waiting to see if the early precursor conditions are progressing. So, do you want to address early detection in the age of COVID? Because I think that's really important.
I think, the whole concept of early detection is I think evolving, right? I mean, we don't want to detect something, one, we can't do anything about, and one, there maybe nothing needs to be done about it, and it just is a cause for worry. So I think increasingly, at this point in time, we don't necessarily recommend that anybody do testing to see if they have a smoldering myeloma or monoclonal gammopathy of undetermined significance, if there is no reason to do those tests outside of, these observational studies like the PROMISE study that Dr. Ghobrial is doing. So, so I wouldn't, if the intent of the question was, should we do screening? I would say no. If you already know that you have a monoclonal protein, we should not kind of delay the monitoring visits that we have been doing just because there's COVID going on. And I think that's what Jenny, what you mentioned in terms of telemedicine is important. We can always have testing done at the nearest clinic that's possible. We can always send kits out from our institutions for patients to get those samples drawn and sent back to us. We can do video visits and we can look at the data together, but don't delay things because the COVID's going on, but no need to go in and actively screen for these.
Mm-hmm. Dr. Ghobrial, what's your opinion?
Yeah. I mean, I agree that we are in an era of COVID-19 and we've all changed, we've all adapted, and there's nothing better to make people adapt other than, the necessity of it. And I think telemedicine hopefully will stay with us where it's easier for you, going to the local lab area where, again, you're safe, wear your mask, but go get your blood drawn. I would be careful that don't delay things too much because of COVID-19. Just like Dr. Kumar said, your health, other things will happen too. There was an article recently that many people missed their screening, their usual cancer screening. So we're not talking about, the PROMISE study is brand new. We usually don't screen for myeloma in general. So that's not our standard. But other standard screening has been missed in many people. And that may reflect in the future for other cancers. So we have to also balance that we're careful not to miss many opportunities for all of our healthcare. So again, being careful, don't take risks, but also don't delay your health because you want to make sure that you provide for yourself the best care and hopefully use the new technologies, the telemedicine, the local labs to get tested.
Yeah, I agree. I think that's a great message. And we don't want patients coming in with more bone disease or more kidney issues because they were too scared to go in. I think a lot of the facilities have taken amazing precautions and you can feel, really confident going in.